Hello, welcome, and good day to everyone. On behalf of ICUS, the International Contrast Ultrasound Society, Stephanie Wilson and I, as co-presidents, welcome you. The seminar today is demonstrations from start to finish, liver and kidney. Special thanks to our esteemed faculty, Stephanie, Christine Merrill, and Jessica Stout, all internationally respected experts in contrast-enhanced ultrasound. Again, thank you to our colleagues and friends at Northwest Imaging Forum, the exclusive CME provider for ICUS. Please check our website for any updates, earn free CMEs from any of these seminars, and we hope you enjoy the program. So what is ICUS? ICUS is the only global professional society solely focused on contrast-enhanced ultrasound. We're in 85 countries and growing. Physicians, sonographers, nurses, scientists, industry, and patients. The disciplines include radiology, cardiology, hepatology, vascular, GI medicine, and much more. We are committed to contrast-enhanced ultrasound. It is an essential tool for all modern ultrasound labs. It's safe, reliable, versatile, patient-friendly, and cost-effective. CEUS produces high-resolution real-time images, and it's often known to reduce downstream testing, improve hospital workflows, speeds access to diagnosis and therapy, and is safe for all patients. There's never a charge for ICUS membership or programs. You can join here from this QR code. As mentioned, we have free CME. Visit the website or our mobile app. ICUS webinars for everyone, physicians, sonographers, nurses, other professionals. Check our calendar and registration. All our webinars are recorded and are available on demand. Please save the date for the 40th Annual Bubble Conference, October 1 and 2, 2026 at the Drake Hotel in Chicago, Illinois. You can also hit our website below. Explore the website. It's extensive and is the most comprehensive suite of contrast-enhanced resources. Calendars, registration, guidelines, protocol, training materials, how to set up lab, virtual exhibits by our sponsors. Our app, quick and easy, ICUS Connect for Apple and Android users. We have a monitor that comes out, updates you on study and trends, webinars, conferences, calls for abstract papers, and links to virtual exhibits by our sponsors. Very important, we have a sonographer training resource hub. It's scalable, it's plug-and-play modules for training, links to product labels, webinar and reference materials, and it was developed by a joint task force, AIUM, ARDMS, ASE, ICUS, IAC, SDMS, and updates are pending. Very important, IV Training Certification Part 1, IV Training and Webinars, free CME. Part 2, Hands-on Training, offered by Northwest Imaging Forums and promoted by ICUS. And pending is certification, offered jointly by ICUS, Intelios, and ARDMS. New multi-society expert consensus statement on the safe administration of contrast-enhanced ultrasound. This is in Echo Research and Practice, 2025. The purpose of this document is to empower institutions to allow sonographers, along with other trained medical professionals, to administer ultrasound contrast agents at the point of care, and consistent with the updated SDMS scope of practice and within broad parameters of an individual's training and licensure, while subject to appropriate supervision and meeting or exceeding minimum safety standards. As mentioned, join ICUS, and ICUS truly appreciates our sponsorship and their leadership in the field of ultrasound. At the diamond level, Bracco, platinum, GE Healthcare, gold, Lantheus, silver, Canon, Siemens, Sonoscape, and at the bronze level, Denton's, Fat Roman Studios, Northwest Imaging Forums. Today's agenda. Welcome from better to best, why and how we use contrast. As mentioned, co-ICUS President Stephanie Wilson, how do we get great images? Christine Merrill, demonstration, how to use Select Ultrasound, Christine and Jessica, question and answers, and how to optimize systems and software presented by our industry sponsors, wrap-up comments, and conclusion. Now, it is with great pleasure I introduce our first speaker, Dr. Stephanie Wilson, ICUS Co-President, Clinical Professor of Radiology and Gastroenterology, University of Calgary, Calgary, Canada. Thank you all.
Hello, everyone. I'm Stephanie Wilson from the University of Calgary, where I run a highly successful contrast-enhanced ultrasound department for the abdomen and pelvic indication. I am also the co-president of ICUS, the International Contrast Ultrasound Society. These are my disclosures, none of which have any particular relevance to this presentation. So what about microbubble contrast agents? So microbubble contrast agents delineate vascular structure, and they do this by enhancing the Doppler signals from even small volumes of blood. And most important, and for the first time, microbubble contrast agents allow ultrasound imaging of organ and lesion perfusion in real time. And so when we consider contrast-enhanced ultrasound today, we recognize that we've had a rather bumpy start with a 15-year delay in microbubble contrast agent approval for body indications in the USA. However, we believe that CUS is now ready for prime time. In the US, there is generous reimbursement, which includes both on and off-label indications using any agent and may study any organ. However, I will emphasize that the only organs that actually have approval at this time include the liver for body indications, the heart, and also a special approval for pediatric patients. So when we consider contrast-enhanced ultrasound, what are the advantages to which we refer? So first, there are inherent ultrasound strengths. Then there are the benefits which result from the specific software that's used for imaging CUS. And then, of course, the contrast agents that we use for CUS as compared to those used for CT and MR differ with very important advantages. And so in the end, we'd end up with contrast-enhanced ultrasound, providing us with a dynamic real-time scan, which is sensitive to very small volume vascularity changes. We have resolution of sins, septa, and small nodules with a true representation of vascularity. And this will result in no interstitial contrast, creating pseudo enhancement. And so we will outline all of these as we go through this talk, which is based on examples within the liver and the kidney. So when we consider the inherent ultrasound strengths, here we're looking at 2 tumors in the liver. And so these strengths include that with dynamic real-time imaging and high spatial resolution, we may perform these kinds of bubble tracking techniques, which give us the highest possible resolution. You can see that in the lesion on the left-hand side that we're looking at the discontinuous peripheral nodule puddles of the hemangioma, and on the right we're looking at the stellate vascularity with centrifugal filling, classic for focal nodular hyperplasia, and both of these are benign tumors, and their investigations can stop with these wonderful images. Now, when we're looking at patients with a liver MAC, we start out doing a grayscale examination, and here you can see a large mass within the right lobe of the liver. When we inject the contrast agent, you can see that it's highly hypervascular with a central scarred area. And then over time, we lose the bubbles within the enhanced mass, showing a pattern of late and weak washout. So this is what we see when we store our still images. However, there's an additional special advantage that is unique only to ultrasound, and that is the demonstration of vascular flow. And so we can see here that when we look at the images we take from the vascular images by backing up the movie clip, you can see the beautiful depiction, we can see the directional filling, and the amount of enhancement. And so these last vascular images are not possible to attain on either CT or MR scan. So the vascular details is a unique feature to CUS. And so when we look at the same patient on MRI on the top line, CT scan on the middle line, or CUS at the bottom, you can see that they're all comparable images. However, no one could dispute the incredible advantage of the hypervascularity relative to the background parenchyma on CUS, and then its more definite demonstration of the washout of the tumor. So now let's go on to the specific software for imaging contrast-enhanced ultrasound patients. So the specific software is based on a subtraction technique, which subtracts all of the echoes from the background tissues, and this results in a microbubble-only image with exquisite resolution. So this requires also a narrow scan plane as compared with the wide scan planes that are used on CT and MR images, and also these bubble tracking techniques for vascular detail. And so this particular case that I'm showing you goes back to show the CUS fundamentals. And this is one of the very first scans that we ever performed. That would be well over 20 years ago now. So we can see on grayscale that we're looking at an echogenic mass in the liver with a hypoechoic halo. So the background liver appears gray and the mass appears white with the black rim. So before we go into the bubble injection, here is a pre-injection low MI subtraction image, which takes away all of the echoes from the mass, but additionally, it even takes away all of the echoes from the background liver. So when we start out, there's really nothing for us to look at. However, when we inject the contrast, you can see that at the peak of the arterial phase enhancement, the mass has become white relative to the signal intensity, which is a direct reflection of the number of microbubbles within the field of view. And then as we watch over time, we can see that the liver, in fact, has become brighter because of all of the blood flow delivered to the liver from both the hepatic arteries and the portal veins. And now our tumor looks dark relatively as we show the phenomenon referred to as washout. So these are important critical features which allow us to suggest this is a malignant tumor, and in this case, a hepatocellular carcinoma. So now let's look at imaging with contrast and at the special techniques. So the subtraction technique allows us to have this superior resolution and that microbubble only image. So let's look here at a patient with a kidney mass. So this is a very good CT scan, coronal on the left and axial view on the right. And you can see that there's a mass in the right kidney marked by the gold arrow. And when we look at this mass, you can see that there might be very faint echoes within, but I'm sure none of you would believe that you should have that kidney taken out on the basis of those images. So this is an indeterminate contrast-enhanced CT scan. So then when we go to the grayscale imaging first on the left-hand side, you can see that ultrasound alone has highly superior resolution to the CT scan, and we can appreciate all of those thin septations through the mass. And then when we inject the contrast, you can see even superior information as the microbubbles arrive and they enhance all of the inherent septations within the mass. So this is not just a renal cyst, this is in fact a renal cystic carcinoma. So superior evaluation of thin septa and nodules. Now let's look at another kidney. So here's a patient who has a pre-contrast image on the left. In the arterial phase, we can see that the kidney and the mass lesion protruding from the edge of the kidney have both enhanced. And in the neprographic phase, which is later, we can see that the kidney remains enhanced and the lesion exophytic to the kidney is barely enhanced, if enhanced at all. So here again, this is indeterminate. Is that a solid mass, a cystic mass, or a complex mass? Those are the questions. And so when we look with contrast-enhanced ultrasound, we can see the mass lesion is cystic on the grayscale image on the left with septations within. And then when we inject the microbubbles, there is no doubt that there's beautiful enhancement of all of those septations. And this is, of course, another cystic renal cell carcinoma. So CUS makes a consistent contribution to the diagnosis of cystic RCP, as CT and MR scan will often fail to show the enhancement within thin septations of a cystic mass. So cystic renal cell carcinoma is a special area for CUS. So CT and MRI scan, due to volume averaging and they're based on their slice thickness, they have difficulty showing enhancement within the septations of cystic renal cell carcinoma and in fact within cystic tumors all over the body. So this results in an indeterminate result from those imaging modalities. So contrast-enhanced ultrasound shows cystic renal cell carcinoma with easily seen enhancement of the septa. It also shows other renal diagnoses with equal proficiency. So let's look at another patient. This is an elderly patient who is a patient with inflammatory bowel disease on Humira. And the patient has an incidental mass on ultrasound. So when we look at these images on a CT scan, we can see on the left unenhanced image that there is a kidney shown in axial view with an exophytic mass. And then the central image is the arterial phase and then the nephropathic phase. And you can appreciate very easily how much greater is the enhancement within the kidney than it is within this exophytic mass, which looks like it perhaps doesn't have any enhancement at all. And so when we look at the gallbladder in the same sequences, we know that the gallbladder is full of fluid, and the gallbladder has got a similar relationship to the enhanced liver parenchyma, looking low attenuation relative to the liver. And so if we look at the two pictures showing the gallbladder and the kidney mass together, we can see this same low attenuation mass. The gallbladder is low attenuation, and so is this mass in the kidney. So the person looking only at subjective information would interpret this as a probable cyst arising from the kidney. Now, they are both low attenuation, but are both of these regions actually cystic? So when we go to the addition of Hounsfield units on CT scan, we can see that on the baseline scan on the left that we can't determine anything about the kidney. And the mass relative to the kidney shows a 20 Hounsfield units change between the unenhanced view on the left and the most enhanced view on the right-hand side. And so this was reported as indeterminate on the basis of this subjective feeling that this looks like a cyst. So they recommended to do MRI. So when the patient goes for the MRI scan, this is showing the Hounsfield unit, sorry. And when the patient goes for MRI, you can see here, looking at the gadolinium enhanced images at the bottom as compared to the pre-GAD image on the top, that there's no significant enhancement of that exophytic mass. And so this mass is reported as being inconclusive for an enhancing mass. However, the patient came to see us because of his inflammatory bowel disease. And so here we can see this mass protruding from the kidney. And when we look at the mass on the grayscale scan, this looks like it's a solid mass. However, when we inject the contrast agent, we can see that the kidney very quickly hyperenhances. And the mass, is there any dispute? Absolutely none. This is a vascular mass, although less vascular than the kidney. And so we know that this is an exophytic, solid, enhancing mass. And the fact that it has less vascularity than the kidney is consistent with a papillary renal cell carcinoma, and this was confirmed on that surgery. So papillary renal cell carcinoma shows always as a solid mass on ultrasound and an enhancing mass on CUS. Its enhancement, however, relative to the kidney is low, creating a potential for misdiagnosis as a cyst or a complicated cyst on CT and MR scan, as happened in this case. And so this problem with papillary carcinoma has caused interest from multiple investigators, and this lovely CT scan performed with a renal cancer technique shows the hyperenhanced kidney relative to the low enhancement of the papillary carcinoma, something that's easily seen on routine CUS. So after the liver, the kidney has become the most established organ in the body for CUS characterization of masses. And two pathologies in the kidney in particular demonstrate the superior sensitivity of CUS to its tracer, and these are cystic renal cell carcinoma and papillary carcinoma, both of which I've shown to you. Now, what about going back to the liver? So the specific software for imaging CUS with this subtraction technique is very valuable to our images. And here we have a patient with HCV cirrhosis who a surveillance ultrasound shows this exophytic echogenic mass. So if we come to time 0, so we've gone into our subtraction technique, you can see the pulse inversion technique or similar makes the pre-injection image look dark. So only the abdominal bang from the transducer and the margin, the serosal margin of the liver are shown at 0 seconds. Now, when we inject the microbubbles very promptly, the liver enhances, and you can see the hyper-enhanced tumor corresponding to our mass shown on the surveillance scan, and we can see it feeding artery. After we look in the arterial phase, we then do intermittent imaging, and at 2.5 minutes, you can see that the mass is showing washout with declining the enhancement of the mass to less than the parenchyma, and you can see there are still bubbles left within. So this is slow, weak washout. This is classic for HCC. And if we look at how we acquire those beautiful images with Larsen, we do this in dynamic real time, storing a cine file, and you can see the bubbles arrive, the rapid complete enhancement of the mass, and at this point we stop our clip, and then we back up and take the images from the acquired clip. So this is the classic enhancement for hepatocellular carcinoma. Now, when we're looking at patients with liver masses, we have to recognize a very important fact, and that is that malignant lesions are not diagnosed by their arterial phase pattern of enhancement. And so what does lead us most often to be suspicious of malignancies is the malignant lesions are predicted especially by the presence of washout. So here we're looking at two different patients, one on the top line and one at the bottom. And you can see in the arterial phase images on the left that both of the tumors show arterial phase hyperenhancement. And then when we go to the portovenous phase images on the right, we can see that if we ask about patient 1 on the top line, and is there washout, and if the answer is no, then you should generally be thinking, could this be a benign lesion? But more importantly than that is if we answer if yes to washout, then we have to always consider that malignancy is a high likelihood. So the biggest indicator of malignancy is washout, shown exquisitely well by microbubble contrast agents, which remain intravascular and always give us a true indication of the blood supply to the tumor at the time we obtain the images. So what about liver mass characterization? So looking at HCC and cholangiocarcinoma as the most common primary liver tumors. So here on the left, we can see on grayscale a nodule in the liver. We see that there is arterial phase hyperenhancement at 30 seconds. And then at 1 minute, we can see that there is no weak washout. Their lesion is still enhanced, equivalent to the liver parenchyma on the 1 minute image. However, as we continue to do our sequential imaging, we show weak washout at 5 minutes. So this is a classic HCC, or according to LIRADS and LR5. So is this ability to see this transferred to our ability to differentiate HCC and ICC? So let's look at two different patients. The patient at the top has HCC, the patient at the bottom has a cholangiocarcinoma. So when we look at the grayscale image, one has an echogenic mass and one has a black mask. And this difference in echogenicity makes no difference to the diagnosis. So if we look at our 30-second or 12-second images respectively, you can see that both of the lesions have got arterial phase hyperenhancement. So does this help us? Not at all. We just know that it's a hyperenhancing mass. However, when we come to the 1 minute image, this is where the action starts. So we can see that the liver cancer maintains all the bubble enhancement and doesn't show any evidence of washout, whereas on the bottom line, the cholangiocarcinoma shows the washout. And then later they both show washout, but the LR5 or HCC at the top occurs at 5 minutes, whereas the LRM tumor, the cholangiocarcinoma, shows late week washout. So what in fact is the most distinguishing feature? It's what happens at the 1 minute interval. So HCC will always show sustained enhancement, whereas the non-hepatocellular malignancies, including cholangiocarcinoma, will not. So here's another patient 1 and patient 2, both elderly females with cirrhosis and risk for HCC. So when we start off, both of these patients have got a large mass in the right lobe of the liver. And although they look different here, it doesn't help us to determine what they are. So then when we look at them in the arterial phase, we can see that at wash-in, they both have heterogeneous hyperenhancement. Again, we don't know what this is. However, if we look further at the 1 minute image, which we can see that's on the left of each sequence, that the HCC on the left continues to show the enhancement, whereas the ICC on the right shows the washout by 1 minute, the distinguishing feature at 1 minute. And then later they both show washout, and so we know that the one on the left is an HCC because of that sustained enhancement with late week washout, whereas the patient on the right with the cholangiocarcinoma has rapid and marked washout, very distinguishing. So CUS easily shows the characteristic features to suggest whether the tumor we are looking at is a hepatocellular or a non-hepatocellular malignancy here in the portal venous phase based on the different washout parameters. So now let's look at 2 similar patients at risk for hepatocellular carcinoma. So these patients both undergo Q6 monthly surveillance for HCC nodules. And so here are their surveillance scans. So you can see patient 1 on the left has got a mass at the superficial aspect of the liver, as does patient number 2. Both of these are marked by the arrow. So we don't know what these are, but they're small hypoechoic nodules. So both of these patients were sent for MR scan as their first imaging test. And you can see that on both of these patients, they have arterial phase hyperenhancement and no washout. And so these are indeterminate results. They could be tumors, but they could also be shunts, which are commonly seen on MR and CT scans. And so these indeterminate patients both come for CUS. So patient number 1 on the left, you can see, has got a very characteristic wash-in. As the bubbles arrive, they come from the periphery, they make nodules that go centrally, whereas the patient on the right has got globular hyperenhancement. So what do we know from this? Well, that filling pattern and direction for the lesion on the left is characteristic of something. So we can see the difference in their wash-in pictures on the top line. And in the portal venous phase, we can see that the lesion on the bottom shows sustained enhancement with no washout, and the patient on the right has got a weak washout. And so what do we know? We know that the lesion on the left is a benign, insignificant hemangioma, and the lesion on the right with late and weak washout is a hepatocellular carcinoma. So here's another patient that shows the value looking at the contrast agents. So the contrast agents for contrast-enhanced ultrasound are purely intravascular, and malignant tumors will show arterial phase hyperenhancement and washout, whereas the interstitial contrasts, which is typical of CT and MR contrast agents, the contrast agent may leak into the interstitium of the tumor. And so malignant tumors will show progressive enhancement that does not reflect the vascular enhancement pattern. So this is a 41-year-old male with alcoholic liver disease with a focal liver mass shown on MR scan. So you can see the mass on T1 imaging on the bottom left. It's a dark mass on T1. And in the arterial phase on the central image, you can see that the arrow marks heterogeneous enhancement with a rim pattern and central and echogenicity. And then on the delayed phase image on the right, we can see that this enhancement state does not show washout. And so this patient was referred from this scan, which was indeterminate, for CUS. So when we look at this patient on CUS, we can see that the mass is highly echogenic on baseline, and that when the microbubbles arrive, watch this very carefully, you can see that the mass instantly becomes hyper-enhancing, and then right before your eyes, it started to wash out. So this mass has hyper-enhancement with very rapid washout, and so this makes this a lesion that is an LRM. So if we look at this lesion on the CUS on the top and the MR on the bottom, we can see that in the arterial phase, the mass is hyper-enhanced, whereas in the portal venous phase, the ultrasound shows striking washout, whereas the MR scan shows increasing enhancement. And so this is a biopsy-proven cholangiocarcinoma. And we emphasize that it's the discordance between CUS and CT and MR scan, which in fact is diagnosis. And this is related to the interstitial contrast agent on MR and CT scan, which does not reflect the vascular pool. And so this is a very old schematic made for me by one of my students. And this shows what happens when we inject contrast on CT and MR scan. And it shows that the intensity of the enhancement does reflect the vascular volume, but more than that, it reflects the degree of vessel permeability, which allows the contrast to pass into the tumor interstitium. And if we compare that with some microbubble contrast agents, you can see that following their injection, that they are constantly within the vessels and do not cause any interstitial enhancements. And so what do we suggest on the basis of this knowledge is we actually suggest that reading of contrast-enhanced ultrasound and MR together provides the best result. And so here at the 71-year-old male who has a nodule on a surveillance ultrasound, and his first test is an MR scan. So you can see that the T1 image on the left has an arrow pointing to a very tiny sub-centimeter mass. So when we look at the arterial phase, portal phase, and delayed phase, we can see that on all of these images, there is a tiny enhanced nodule with no washout. And so do you think that this would be diagnosed as a cholangiocarcinoma on MRI scan? No, it wouldn't be. Most likely, MR scan would recommend a repeat MR scan in 3 months' time as a follow-up scan. So in our institution, this little mass was referred for TUS. So when we look, we can see the mass on the ultrasound, and we can see that when we inject the contrast agent, we see rim hyperenhancement. So at 20 seconds, we see a rim, very nice bright rim around this little tiny mass. And so then when we look at 23 seconds, we can still see the rim, whereas at 30 seconds, the rim is gone. And absolutely certainly at 1 minute, it's completely gone. And so what do we know? That this is not an HCC. It does not have delayed weak enhancement. It has rapid marked washout. And so this little tiny mass measuring only 8 millimeters is a biopsy-proven cholangiocarcinoma. So what about this patient? This is a 65-year-old female with no liver risk factors. So in 2019, she had a clinic ultrasound, which we managed to get a hold of. You can see that deep in her liver, she's got a collection of little tiny black masses with white walls that look as though they represent little cysts. And so this was felt to be a benign lesion and nothing happened. However, in 2022, she had an MR scan, and you can see that on her MR in the T1, this is a bright nodule. And so this brightness was maintained throughout all the sequences, which demands that we have to look subsequently with subtraction. So in the arterial phase, there's nothing very convincing of vascularity. However, on the most delayed subtraction image, there's unexplained central echogenicity. So this patient has an indeterminate result and came for ultrasound. So you can see that now this is what we show on the ultrasound, in no way similar to what we saw previously with those tiny cysts. And so when we do contrast-enhanced ultrasound, we can see that this is a hyper-enhancing mass. So we see globular hyper-enhancement. And then when we look at our delayed images, we can see that the globular enhancement At 1 minute is weak washout, and at 2 minutes it's marked. So we said flat out, right, this is malignant, and we must biopsy this. And this is actually a metastatic ovarian cancer, unsuspected in the ovary. And almost my last thing I'm going to talk about briefly is this is a patient who's pregnant, 32-year-old female, 17 weeks pregnant, and she has a scan for inflammatory bowel disease. So when we look at her bowel is completely normal. But in my department, we always do a thorough scan until my stenographer brings me these beautiful pictures of a kidney. So there's a lovely kidney, and we can see this big, big mass replacing the whole lower pole of the kidney. This is a 32-year-old girl. So this mass shows hyperenhancement and washout. So this is a cancer. So we called it a cancer. And this patient had a heminephrectomy during pregnancy with never having a single CT or MR scan. And this is a confirmed chromophobe carcinoma of her kidney. Really miraculous case, and with great gratitude to physicians feel that they can handle patients with malignancies with the use of CUS during pregnancy. So what have we talked about? Well, the CUS advantages without question include that this is dynamic real-time scanning of blood flow in organs throughout the body. Bubble tracking techniques are invaluable, especially for tracing blood vessels for diagnosis of benign liver tumors. And of course, exclusion of malignancy is just as important as conclusion for malignancy. And so you just cannot compete with this kind of incredible vascular resolution. So the use of purely intravascular microbubble contrast agents with the subtraction technique that removes all of the background acrogenicity, creating a microbubble-only image, and our narrows slice thickness. The result of these features let us have a superb sensitivity and resolution of the blood flow that we show. And so our general thoughts is that CUS is an excellent technical and performance advantage. CUS of the liver and kidney. These are not the poor kid on the block. And at the University of Calgary, we do routine performance of liver mat. Ultrasound are the first test following a positive primary surveillance for HCT. We do alternating evaluation for secondary surveillance for patients who have already had a liver cancer, and we're fully integrated into our multidisciplinary discussion for liver cancer patients. And of course, we use it for guidance for ablative therapy as well, with a full day of our week dedicated to helping them do these procedures. And for kidney and liver problems, we are regarded as a problem solver for all indeterminate CT and MR scans. Thank you for your attention. Hello, I'm Christina Merrill from Calgary, Alberta, Canada. I work at the Foothills Medical Center in the lab of Dr. Stephanie Wilson, and I've been practicing abdominal contrast for 15 years. I'm also a sonographer member on the ICUS Board of Directors. So we're going to talk a little bit today about CUS technique and optimization, specifically in abdominal settings. I've called it from blurry to brilliant, and we're going to transform CUS imaging in liver and kidney. I would also like to thank Dr. Stephanie Wilson, who is integral in all the presentations that I do. Disclosures, I have none. The grayscale ultrasound for liver and kidney is well-established imaging modality. Ultrasound contrast agents, when added to traditional grayscale ultrasound, have the ability to add detailed information about blood flow at the microvascular level. So this is important because in abdominal imaging, this is an important diagnostic tool. And CUS for the first time becomes competitive with CT and MR, and it requires a new understanding of technique and application. The North American standard is reliant on sonographers, as compared with many places in the world where sonographers are not part of the team. So diagnostic imaging using CUS requires protocol and technique. In this talk, we emphasize the fundamental to achieve excellent diagnostic images with a focus on liver and kidney. So we know that ultrasound is operator dependent, and this is often seen as a limitation for its use. But CUS requires acquisition of a new skill set. Quality and technique are essential to maintain the accuracy and diagnostic capability of contrast-enhanced ultrasound. consistency of protocol allows for comparison of studies over time, and it improves efficiency. So CEUS technique is a combination of movies and still images that are obtained for optimal diagnosis, and CEUS LIRADS clearly defines acquisition, still images, and movies required for essential diagnosis, especially in the liver. But how do we get these images? We're going to look at the fundamentals of performance, and then we're going to look at these techniques specific to liver and kidney imaging. So this includes patient positioning, bubble administration and setup, software and windowing, and probe positioning and focus. So patient positioning and setup. So you can see our sonographer here on the left and on the right. It's likely supine or decubitus. The probe arm is resting in a stabilized position like you see on the left. And that's because during contrast imaging and abdominal scanning, we have long acquisition times and we require stable images. And so the arm support helps us to acquire stable images, and subtle movements are required during live acquisition. On the right-hand side, I often see this with new users and sonographers in CEUS. And you can see that her arm is floating above the patient and her hand is also floating above the patient. This does not allow for any stability when you're trying to acquire your images. So bubble administration requires 2 people, one person to inject the bubbles on the left-hand side of the patient and a second person to scan on the right-hand side of the patient. These 2 people need to coordinate because on the left side, the person injects the contrast in the saline flush, and on the right side, the person scanning must start the timer on flush start and start the clip on first bubble arrival. So preferably you want to use an antecubital vein in the left arm, and you can use almost any vein. So the positioning of the tubing should have no sharp turns or kinks. The clamps, all valves should be open and in the correct position. We'll talk a little bit about that coming up. And as for vendor guidelines, preferably you want to use an 18 gauge. But tip of the trade, if the patient cannot tolerate a large gauge needle, you can also use a smaller one and inject slowly. The proper setup is it for liver, kidney, and abdomen techniques is a 3-way stopcock short tubing technique. So you can see here in our picture, we have a short tubing with a clamp. We have the saline plus flush positioned 90 degrees to the tubing, and then we have the contrast-filled syringe in line with the IB tubing. And again, 18 gauge is recommended, however, it's not strictly used. We see a lot of problems with valve direction in the 3-way stopcock technique. So we're going to talk a little bit about this. So here, when you have the valves closed, the off position should be pointing to the tube you want to be closed. In this case, it's the saline tube. So when you inject the contrast, it's in direct line with the IB tubing. And then when you turn the stopcock to the contrast syringe, inject the saline flush, and then it moves into the tubing. Incorrect position, the contrast will move in the wrong direction. So in this case, the off position of the stopcock tubing is towards the tubing, and the contrast will end up going back into the syringe. And in this case, the off position is not in line with the contrast, the saline, or the tubing. So the contrast will go everywhere. Abdominal imaging exclusively uses a bolus technique, which is the rapid infusion of saline after injection of contrast. What it does is it concentrates the bubbles in solution, provides optimal enhancement in the arterial phase, and it facilitates the movement of any remaining contrast in the tubing into the bloodstream. If you want to inject the contrast first, in line with the tubing so the contrast solution does not encounter any resistance during injection, and then you want to bolus the saline flush. Any resistance or pressure against the contrast or the saline will blow the bubbles. So just some points to remember when you're doing injection of contrast. The bubble mixture separates quickly, so you want to give the syringe containing the contrast solution a firm shake between injections. You don't want to use IVs with filters, and remember that a drop syringe or vial will likely destroy the bubbles. It's important to have a quick look at contrast software. I think Dr. Wilson talked a little bit about the subtraction technique in her talk. So here we have a dual screen display. And we have the low MI grayscale image on the right-hand side, and then we have the exclusive microbubble only image on the left-hand sides. We use dual calipers. When you place a dual caliper on the left-hand side of the screen, it'll populate to the exact same position on the right-hand or grayscale side, or vice versa. We have a timer. It's important to know the location of the timer. And then you have to make note of mechanical index, which is usually quite low for the abdomen. We'll have a look at that. Abdomen and kidney scanning, you often use between 0.06 and 0.09 MI on most equipment. So this is the importance of mechanical index. We call these our contrast martinis. So mechanical index is a measure of power. It's static on some machines and changes with probe and focus on the others. It's important to note the mechanical index level prior to each injection. Bubbles exposed to a high mechanical index are often disrupted. So on the left-hand side, we have some bubbles that we've placed in a cup full of water, and we put the probe in the cup. And the mechanical index is about 0.59. And on the right-hand side, the probe placed in a cup of water with bubbles in it, mechanical index is about 0.08. So you can see the difference in what happens. You get avid bubble destruction on the left-hand side, and on the right-hand side, you have even distribution of bubbles from the near field to the far field in this cup. Gain is important. So grayscale and contrast gain are adjusted independently. So prior to injection, so we'll just show you have your grayscale side, your low MI, and then prior to injection, you want to adjust the contrast gain so that there's no background noise. So you turn your contrast gain up, and then you pull it back till the image is fully suppressed or the tissue is fully suppressed. Your TGCs should be aligned and straight. Probe orientation. So in this image, you can see we're using an intercostal window. On the left-hand side, you can see there's a big central rib shadow going down that screen. And on the right-hand side, we're slowly rotating the probe in the intercostal plane to open up those rib spaces. And you can start to see the lesion once we do that and we remove the shadowing from the rib space. So the intercostal windows are quite common for us. And they're often in an oblique plane, not necessarily sag or transverse. Respiration is really important. When using quiet breathing, the lesion should be continuously visible. A big breath in or suspending respiration may be required for the best window. So you can see here the probe is aligned, perpendicular or oblique to the plane of respiratory motion, and the lesion is intermittently visible. Window selection. So this is a grayscale image of a mass, and you can see the image on the left is a subcostal approach, and the image on the right is an intercostal approach. For a grayscale, the image on the left would appear to be the better image. For contrast, watch what happens. This is the same lesion in the same liver. The subcostal approach, the lesion is deep in the liver, and the lesion is vaguely defined. The intercostal approach places this lesion within 10 centimeter depth as a near field, and then it is obviously visible. So the take-home point here is that the optimal grayscale window is not always the optimal contrast window. As you can see on the left-hand side where the lesion deep is vaguely defined, and in the intercostal window, it's avidly enhancing and well circumscribed. Scanning pressure is really important. We've seen this happen many times with new sonographers. On the top image, you can note that there's uneven bubble filling with fewer bubbles in the near field. You can see a hypoechoic rim forming around this hyper-enhancing mass. There is not enough time for there to be bubble destruction here, so this is caused by excess probe pressure. When we decrease the probe pressure, you can see that there's normal perfusion around this enhancing mass. Bubble distribution. So the goal is to attain even bubble distribution from the near field to the far field, as you see here, using low MI or intermittent scanning. And how do we do that? So some tips to obtain that are here. So contrast dosing. We get big signal enhancement from a small amount of microbubbles
too much contrast causes oversaturation and absorption of the ultrasound signal. So you can see here, this is too much contrast on this image, and there's absolutely no signal in the background liver. Tips of the trade: new users may confuse this with a software limitation or issue with penetration. Optimization of dose will correct the problem. Focus. So this is a bit different than grayscale imaging as well. You want your focus placed at or below the structure of interest. Focus set at the incorrect depths create differences in penetration and bubble uniformity between the near and the far field. So although we don't move the focus during scanning, we created this clip to show the impact of changing the focus in real time. You can see as the focus moves up, you completely lose the image in the background liver. And as it moves down, you have better bubble distribution from the near field to the far field. So let's put these together and look at a case of liver and kidney imaging. So the liver has a dual blood supply. The blood is supplied to the liver, 20% of it by the hepatic artery and 80% by the portal vein. This affects how we image. We must make note of the arterial, late phase, and portal phase. So here we have our image acquisition in the arterial phase. You want to start your timer at the end of injection or saline flush. You want to obtain a continuous movie clip from first bubble arrival to peak enhancement, and you want to take a still image at peak enhancement, as we have here. You want to note your mechanical index and focus at the back of the screen. And we have even bubble distribution enhancing mass with even bubble distribution from the near field to the far fields. And then we want to do intermittent scanning. So we take a picture at 1 minute, we stop scanning, take a picture at 2 minutes, stop scanning, take a picture at 3 minutes, stop scanning, and take a picture at 4 minutes. What this will do is it will show the liver and the lesion in its entirety, including the liver from the arterial phase, the venous phase, and then the late phase. The kidney only has an arterial and venous phase. So we do look at the venous phase in the kidney, but the arterial phase is the most important for the detection of masses. We're just going to do a quick look at the kidney here. So we have our grayscale ultrasound. We want to try and include the entire kidney. And again, we want to try and make it less than 10 centimeters depth from the near fields. And you can see the beautiful arterial phase wash-in. We've optimized the imaging from the near field to the far field. And then in the late phase, you can see, or venous phase, you can see the kidney washed out. In the left kidney, you can see here on the left-hand image, we have the spleen. And so the spleen is essentially a big bag of blood. So what happens is we're getting bubble absorption from the spleen, and we're not actually getting any image in the upper pole of the kidney. So repositioning can help with image optimization. So here you can see we just repositioned the probe a little bit, and now we're getting adequate blood flow in the top of the kidney, or adequate bubbles. So CUS has a demanding learning curve for all medical fields, physicians, radiologists, and sonographers alike, and it will require further development and curriculum. And if everyone is moving forward together, then success takes care of itself.
Next, we're going to review some fundamentals of placing a peripheral IV. As we know, contrast is not widely used because of workflow barriers, one of which is obtaining an ID. So this is an excellent skill set for our sonographers to have, and it will reduce workflow barriers when using contrast in our labs. So I'm going to turn it over to Christine, who is going to go over how to place the IV.
Okay, so first we're going to review the components needed before you start your IV and IV setup. So on the table beside me here, we have in orange a tourniquet, we have Tegaderm, we have the IV needle, in this case the butterfly needle, we have alcohol glove, and then we have gloves. So the first thing you want to do is make sure that you wash your hands before every IV start, and then you want to don your glove. Make sure the patient's arm is resting and in a comfortable position. And then you want to take the tourniquet and then apply the tourniquet just above the vein of intract. Usually we're using the antecubital vein, as these are big veins and suitable for contrast imaging. You want to palpate the skin, looking for the right raise of the vein. You want a vein that's soft and compressible, and you want to make sure there's not too many valves within that vein. So here, you can see that there's a good vein, although it's on an angle. We're going to take our IV kit, open the IV, just prime our butterfly needle. We want to make sure we remove the plastic cap. And then when we insert the IV, we want to make sure we insert it in line with the vein. Prior to insertion of the IVs, we're going to make sure the area is clean. Use an alcohol swab and swab from the inside out. Now placing again the butterfly needle in line with the vein, we want to angle. We want to make sure that the bevel of the IV is facing upwards. We want to angle the IV on a 15 to 20 degree angle at first insertion. Insert it into the vein. Lower the needle parallel to the skin in the vein, and then guide the catheter in along the needle. We want to remove the needle and the capping, and then the only thing that is left into the skin, you'll see flashback from the needle, the only thing that is actually left in the vein is the small catheter. You want to clamp the IV once it's in. Okay, and then remove the tourniquet. Now with the patient in a resting position, you want to take your tegaderm, making sure the area is clean. Open the tegaderm up, remembering to keep it sterile. Slide the backing off of the tegaderm. You don't want to touch the surface, but you want to keep it sterile. And you want to use this to position and hold the IV with the plastic tubing coming from the, in this case, the corner, where there's a slit designed for the plastic tubing, and then you want to remove the tape. And then your IV is ready to go. Prior to injecting contrast through the IV, you want to make sure that you flush the line. Usually we do this using a 10 cc saline flush. Make sure the air is out of the saline flush. Take the small protective capping off the IV. Insert and to twist the saline flush, do or lock syringe into the IV. Open the lock. Withdraw, and you'll see some blood coming back into the tube. And then you want to feel as you flush the line, and you can feel it going in smoothly into the IV. Close the clamp on the IV, and then you're ready to go and hook up your contrast setup. So now we're going to talk a little bit about how to remove the IV. So you can see here our IV setup is complete. The clamp is closed. We're going to start by taking off the tegaderm. Sometimes we put a finger on the IV so we don't pull it out rapidly, and we're just going to remove the tegaderm slowly around the IV. Being careful not to touch the tubing into the skin. We fold the IV, then we take a small gauze, place it on top of the IV, and withdraw. Then we take the tape, and we're going to put it on top of the gauze. You can ask the patient to bend their arm or hold pressure for at least 2 to 5 minutes. So hello, we're here today to talk about the administration of Optithon in abdominal application. And here you can see we have our Optithon vial. It is a perfluorine microsphere surrounded by a protein shell. So what you want to do is you want to take the Optison out of the refrigerator, and you'll notice when you take it out that the solution is not homogeneous or clear. So you want to invert the vial and then gently roll it between your hands. Turn the vial back, and then you'll notice that the solution is an even, opaque, milky white. And then you know that you're ready to go. You want to remove the cap from the Optison. Use the alcohol swab to disinfect the top. So with Optison, you need to vent the vial. There are two ways to vent the vial. You can vent it with a needle, or you can use a vent spike. So we have a vent spike here today. So you want to take the cap off the vent spike, insert it directly into the Optison vial, take the cap off the top of the vent spike, and then you can withdraw your contrast solution through the same vent spike in this case. So we will take our 1 ml syringe. For abdominal scanning, we only use small amounts of contrast agent, or Optison in this case. Turn the vial upside down, and then draw the contrast into the syringe. You want to be careful not to push the contrast back into the vial, as this creates pressure and may blow the bubble. So ideally, on average for abdominal scanning, we draw up about 6 mil. In liver scanning, it's 0.2 mils per injection, so this could allow for 3 injections. We take the syringe off the vent spike, and we're going to attach the syringe to our 3-way stopcock. And we're going to attach the syringe with the contrast agent in line, and you'll see, with the tubing. We're going to take our 10 cc saline syringe, take the cap off, make sure the air is out of the saline vial, and then we're going to attach the 10 cc saline syringe attach the 10 cc saline syringe 90 degrees to the contrast solution and 90 degrees to the tubing. We're going to take the cap off the top of our 3-way stopcock, and then we're going to hook it up to our IV line. Place it in the IV line, and then we're ready to go. And then once we start the injection, you want to inject about 0.2 mils of contrast agent. You want to turn the stopcock to the off position, and then bolus the 10 cc saline flush. And you make sure you clamp when you're finished, and then you can proceed to take your images and then move on to the next injection. And you're going to use another 10 cc saline flush. You want to replace the flush with another 10 cc syringe. And you want to make sure that you agitate the contrast between injections, because the contrast can easily fall out of solution. Turn the stopcock to the off position for the saline flush. Open your clamp. Inject another 2 mils for your next injection of Optison. And then you want to again bolus the saline flush. Being careful that the clamp or the stopcock is in the right position. You do not want to put any pressure on the bubbles once they're going in through the tube, and then you turn off the clamp. So today we're going to talk about Lumison or Sonaview, which is a sulfur hexafluoride lipid A type microsphere contrast agent. And we're going to talk about the application, abdominal application using the three-way stopcock technique. So in our Lumison kit, we have 1 vial of Lifolite powder. We have a sterile 5 milliliter saline syringe, and then we have a transfer psych system. So what you want to do is you want to take your vial of powder, remove the cap, make sure it's clean and sterile with an alcohol swab. And then you want to take the transfer spikes and insert it into the powder container until you hear a click. You want to take the saline solution, remove the cap, open the top, and twist the saline into the top of the tube. Take your plunger, put it on top of the saline solution, and then you want to inject it into the vial of lyophilized powder. You want to shake the Sonaview solution for about 20 to 40 seconds until the solution becomes a milky white. And then we want to redraw the milky white solution back into the syringe. Making sure not to push it back into the vial. And you want to drop all of the solution and then stop. Remove the contrast vial, the contrast syringe, and you want to insert it in your three-way stopcocks in line with the two bags. You want to take the saline syringe, make sure the saline syringe inserted 90 degrees to the contrast solution and 90 degrees to the tubing. And then we want to take another alcohol swab, wipe off our IB line, and then twist it slowly into the IB line, being careful not to actually twist the IB line. We want to open our clamp, and then for abdominal applications, you want to make sure that your stopcock is turned to the off position for the saline solution on first start. You want to inject approximately per injection 2.4 mils of Sonaview. Some systems now require less Sonaview. And then you want to turn the stopcock to the off position facing the contrast syringe. And you want to bolus the saline flush. So today we're going to talk about Definity in abdominal administration in abdominal applications. Definity is a perfluorine microsphere. So you can see before you start, the vial in solution is clear. Definity is unique in that it uses a mechanical activation system. You want to make sure, called the vial mix, and you want to make sure that the vial mix is in the on position. You want to open the cover and then press down on the latch and move it outward, and then you want to place your Definity with the cap to the left and the bottom on the right. You want to close the cover, and then you can see it automatically starts to 45 seconds, or it populates to 45 seconds, and then you want to prep the on split.
The vial mix is a mechanical agitator. It has an automatic 45-second activation cycle. You want to ensure that once the vial mix is started, you do not interrupt the cycle or lift the cover. Mechanical agitation allows for a consistent size and distribution of microbubbles, stabilizing them in solution. From extensive experience, we find the vial mix easy to use, and it lasts for many years through multiple series of bubble activations.
And then when the activation cycle is complete, you lift the cover, press down on the tab, push it sideways, and remove the Definity from the vial mix. And you'll notice that the Definity is now a clear and homogeneous, milky, opaque white and fully activated. They're going to remove the cap off the top of the Definity, keeping everything clean. You want to make sure you use an alcohol swab. You want to take your needle, press it into the Definity to vent the vial. Venting the vial helps release any negative pressure when you're withdrawing the solution. You want to take your 1 ml syringe, remove the cap, and place the needle on the top of the 1 ml syringe. This is a Luer lock syringe. Take the cap off, and then you want to place the needle directly into the vial. Invert the vial, and then slowly withdraw the Definity. Often for abdominals application, the average volume that we would withdraw is 0.6 ml. Want to take the needle out of the vial, remove the needle cap from the syringe, and then place it on your 3-way stopcocks. Making sure there's no bubbles within the solution. You can gently tap the solution to remove the bubbles or air from the tubing. Then you want to take your saline syringe and you want to attach it 90 degrees to your contrast and to your extension tubing. So you notice here the off position is facing the saline syringe. You want to clean your IV line. And then gently turn the 3-way stopcock into the IV line, being very careful not to twist the tubing. You want to make sure you open the clamp. And generally for abdominal imaging, the average is 0.2 mils per injection. But for kidney or bowel, we may use a little more or a little less. So the stopcock is now in the off position, facing the saline syringe. You want to inject 0.2 mils of Definity. Turn the stopcock to the off position to the contractor end, and then you want to bolus the saline flush. And then make sure you clamp your tubing. At this point in time, the sonographer will be scanning, optimizing her image, and for abdominal or liver imaging, she could go up to 4 to 5 minutes. So while you're waiting, you can remove your saline flush, attach a new saline flush, in preparation for the next injection. Turn your stopcock to the off position on the saline flush and make sure that you agitate or gently shake the bubble in between injections. When the sonographer is ready or prompt you to start, you open the stopcock and she will gently say how much contrast she needs. Do you want to inject again? Another injection, subsequent injection at 0.2 mil. Turn the stopcock to the off position on the contrast tubing, and again, bolus the saline flush. Make sure your clamp is off, and break.
Well, welcome, Dr. Wilson, and welcome, Christine, our two faculty here to answer questions. We have a few lined up here.
Thank you, Matt.
So it looks like, did you want to start with the Q&A here? Ones, do renal masses often present with inflammatory bowel symptoms?
Oh, I'll answer that question. I suspect that question was motivated by the case we showed. The patient incidentally had inflammatory bowel disease, and when we scanned his entire abdomen, which is our habit, we happened to notice the mass in the kidney, which we characterized. But no, they do not go together.
Okay. Can you give tips for patients that are thinner or have rapid breathing? Could you use a linear probe?
Yes, we can use a linear probe. So on all systems, the manufacturer decides on which probes they will put the software for performance of contrast ultrasound. So the thing that we have to recognize, though, is that the bubble oscillation is actually ideally found within the range of the standard abdominal probes. And so as you go to a linear probe, you have more small bubbles. And therefore, although we have improved resolution with a high frequency probe, we require more bubbles to be injected so that we continue to have a uniform and substantial number of bubbles within the field of view. So we do always pay attention to the transducer frequency that we're using. And so although in the abdomen we very regularly use both like a 1.5 and then a 3.7 or a higher frequency, going all the way to a linear probe, we're always so excited to do it, but it's often does not produce the benefit that we hope to attain.
Fantastic. Thanks, Dr. Wilson. One quick question on getting the PowerPoints recording. Looks like all the recordings would be available on ICUS, as Dr. Feinstein had represented. Definitely go to the ICUS website for that. Why inject saline after contrast? Wouldn't that dilute the solution? First question. Also, why would you need several repeats of injection?
Am I the only person that's answering? I'm happy to, but
I'm here too, Dr. Wilson. If
yeah, why don't you answer that one?
Okay.
Answer.
So when we use the contrast, we're using such small amounts of contrast that sometimes it can get stuck in the tubing. So sometimes the saline solution or the 10 cc bolus is just to help move that solution through the tubing. But it also, what happens when we do bolus injections, it concentrates those bubbles within solution. So we get a big hit in the arterial phase when we push behind with a 10 cc saline syringe. So it doesn't actually dilute the solution. And I'll ask Dr. Wilson to comment on that.
Yeah, no, Christine, that was great. I completely agree. And the other thing, of course, is brought out by this very good question is that we use time 0 as the start of the saline flush. And so Christine is absolutely correct. So when we inject the contrast agent from the tubing into the patient, in actual fact, a lot of it, in fact, on DEFINITY for certain, all of the contrast remains within the tubing. And so it's only when we give the flush that the saline, or that the microbubbles actually go into the bloodstream. So the saline flush is very important. And I'll point out that both Richard Barr and I, who have been doing this probably longer than anybody else, we used to give a 5 ml slow injected saline flush, and now we give a 10 cc bolus for the saline flush, and we inject it as rapidly as the patient and the IV will tolerate. So we really feel that the bolus, as Christine said, really delivers the contrast to the region of interest most efficiently as a bolus and not mixed in slowly with the blood.
Excellent. So next question could vary depending on the country in which you're practicing. Is a patient-informed consent recommended?
I can answer that, Dr. Wilson, if you'd like.
Sure.
Yeah. Yes, it is. It is recommended. In fact, in our institution here, we use we have a policy that it's a verbal consent, but the patients, and we explain it to the patients before the exam. But I think the consent policies and procedures will be institutional. So they'll vary with where you work and how your institution wants to handle that. Does that make sense, Dr. Wilson?
Yeah, it does. The thing to emphasize here is that, yes, everybody, I think, in the world requires us to obtain consent. And the thing that differs from institution to institution is whether it has to be a signed consent or whether it can be verbal. And so we for many years had signed consent, and CT and MR scan had moved away from signed consent. And so I don't know why that would ever have happened, because the microbubbles are the safest of all of the agents. However, we now use verbal consent only, and so as that this is a recognized valid procedure, a verbal or a signed consent according to your institutional preference.
Excellent. How do you deal with lesions in patients with high BMI? For example, if there is a lesion around 10 centimeters below the level of the transducer.
Yeah, I can answer that one too, Dr. Wilson. So this is a really good question. And certainly when as sonographers and when we're doing contrast, this is something that we're always working around. Right now, we do have equipment with specialized transducers that will allow us to see below 10 centimeters that do contrast. So that's one option that we have. Or in your settings, you want to make sure when you're injecting in the arterial phase, you're using a penetration mode to start. That sometimes will help you get down to 10 to 15 centimeters, depending on your equipment. Also, there's something else that we do. If it's the difference between seeing the lesion and not seeing the lesion, sometimes we will increase our mechanical index. But usually that's sort of, we do that as a last resort. If we can't see anything, then we might take a mechanical index from 0.07 to maybe 0.10, and that helps us get a little bit more depth.
But this is actually an extremely important question. Ultrasound, or as ultrasonographers, we want to be able to continue to participate in the whole patient population. And so let's say we take, for example, the patients with liver nodules and those that are at risk for HCC. So we, of course, have been pressuring ultrasound manufacturers for years and years that we have to have more penetration, more penetration. And so certainly the special transducers that have been designed for larger patients are most important. But even not considering that, all of the manufacturers have improved their software. So they are always striving for the best penetration, the most uniform distribution of bubbles through the entire field of view. And so this is a challenge. And I do believe that there has been tremendous improvement over the last decade.
Can you comment on the future use of CEUS for breast masses? And then a second question, other masses.
I'll leave that one to you, Dr. Wilson.
So you would. So unfortunately, let me just comment. Breast masses and CEUS, I believe, has been probably the least successful venture. And so although there may be people in the world who are using this well, I do believe that by and large, most people have felt that this is not an optimal place for CEUS. So certainly, if you'd asked me where was the least likely to succeed, I would have said breast. Now, where else can we use it really and truly? Other than the breast, I have been so impressed. We have used it in every solid abdominal organ. We use it in the pelvis, we use it in the ovary. We use it in testicles. We use it for masses in the thyroid, really wherever you want to go. These microbubbles are very versatile, and answering this question would come back to the linear probes. So we do, of course, have to really rely on the manufacturers to supply us with contrast capability over a large spectrum of frequency of ultrasound probes. But
Go ahead.
Sorry, I apologize, Matt. We're very excited that in the future, that CEUS will be a more major player in a far greater range of applications than now.
Fantastic. Thank you, Dr. Wilson. Is there a 30-minute waiting period between injections? This one is specifically asking about DEFINITY, but I imagine if you could expand to all three approved agents.
No. So we originally used to always try to clear the bubbles from the field of view and to wait so that it was more like every single time we were doing an injection, we would be on a clear playing field. And it was with experience and time and a little bit by luck that we realized that if you in fact inject microbubbles on top of the portal venous or the late phase from a prior injection, for reasons which escape us actually, you get better arterial phase delineation of enhancement. So now we never clear the bubbles anymore, and we inject multiple times. So within a 30-minute time frame, we might easily have injected 3, 4, even 5 times. And so that's an excellent question, and I hope that this information will help some people, because on-top injections are invaluable for showing arterial phase features.
I believe this next question was a piggyback off of one of the software answers, I believe, Christine, that you may have been mentioning, and Dr. Wilson as well. Are all machines compatible with this software, and who is uploading the software?
I can answer that one, Dr. Wilson.
Good.
So all the ultrasound companies that I have seen, they come with specialized contrast software. And so you have to, when you're buying the machine, you have to make a request to purchase this software. And if the software is loaded on the machine, then yes, you can do contrast. What you have to be aware of if you're purchasing a machine is that which probes on each equipment company are contrast capable, because different companies have different availability of the contrast on each probe. But so far that I've seen all companies have CEUS software that you can purchase along with the equipment.
So I'll add a little bit to that. If we go back, let's say, 10, 15 years ago, there was an interval of time when there were quite a few ultrasound machines, mainframe big ultrasound machines that were out in service, purchased by people, and they wanted to go into doing contrast ultrasound. And so there was an interval of time when you could do an upgrade to your existing ultrasound system. And so there were several instances when I saw these machines that had upgrades. And so my advice to everybody at that point in time was, certainly you can, for much less money, just upgrade your existing system. But it's always better if you can have the system purchased with the upgrade as part of the main operating system. And so today, as Christine has just said, virtually all of the major ultrasound manufacturers have got a contrast package, and they have it on their high-end machine especially, but many of them do have it also on their lower-end ultrasound equipment that they might use for portables or other things where they don't demand the high service machine.
What are some common CEUS artifacts that we should be wary of determining true enhancement?
I'm going to leave this one to you, Dr. Wilson.
Well, actually, I'll start. I'm sure there'll be many more that we'll come to.
Yeah.
The most important artifact that I think we want everybody to be aware of very early in their exposure to ultrasound is the artifact that is created by bright echogenic foci or regions of interest within the field of view, and usually well into an area of imaging. So, for example, if you have a mass that's got a bright echogenic focus within, we will get what's called nonlinear artifact that arises from that bright focus. And so the bright focus, when on your dual screen, you always want to look, well, what am I looking at? And if you look at the grayscale side and you see that there's a bright echogenicity within what you're looking at, be aware that it will get a pseudo enhancement from nonlinear artifact. And so we can't really explain that, I don't think, here in this webinar. However, if you look that up, so it's abbreviated nonlinear artifact, and it is generated by a focus of increased echogenicity within your microbubble region. And this is something that can cause you to think that something has enhancement that is not real. So that would be the most important one. Would you agree, Christine, or what other ones do we want?
I agree that's the main one. I know as sonographers, when we're trying to determine whether this is artifact or not, one of the things we're really looking for is there bubbles moving within that right area that we're looking at? So bubble movement can sometimes help us, but I think Dr. Wilson described the main artifact well.
But and the most important place where we encounter this, in fact, is if you do tumor response assessment following local ablative therapy for liver cancer. So after you've treated a liver cancer, you get coagulation necrosis. So often within the tumor, the tumor might originally have been hypoechoic or echogenic. It doesn't make any difference. But if after the treatment it's got a big echogenic ball in it that represents the coagulation necrosis, when you inject very early on, it won't show any enhancement. But then out of the arterial phase, in other words, after the arterial phase is finished, it starts to slowly enhance and may, in fact, by 1 minute, be very bright. And you may mistakenly think that that's real. So as Christine says, we inject again and we pay very strict attention to the fact that you should only see bubbles moving in your field of view in the arterial phase. And if you start to see enhancement out of the arterial phase, then you should be suspicious of artifactual enhancement. And I apologize for my voice. I'm just recovering from laryngitis.
I believe there's so many of us that are having that wintertime cold as well. We sure appreciate you working through it, Dr. Wilson. Do you use continuous or intermittent cine for the arterial phase?
I can answer that one.
Sure.
So upon first injection, when we say flush start, we will hit our timer, and then just before first bubble arrival, we like to try to obtain a movie clip. So we start our clip, and then in the arterial phase, we'll make a continuous movie or AVI clip, whatever, or MP4, up to about 50 seconds. Now, there are some circumstances where you might have a slightly different lesion and you would go longer than that. So the answer is yes. We will use a continuous cine clip in the arterial phase. And then after the arterial phase, we will do intermittent scanning at 1 minute, 2 minute, 3 minute, and 4 minute to try to preserve the bubble population.
That's excellent. And I'll just emphasize one of the reasons for doing continuous recording of the arterial phase is that it is unbelievable how you can forget. If you only watch it one time, and then let's say an hour later, you go to dictate the report or to write your impression of what happened. It's totally different often than what actually did happen. And so we look at them, we relook at them, and we relook at them until we really feel we know what actually really did happen and at what time interval. So it's very important to do that continuous arterial phase recording.
Excellent. Do you have experience with 3D, even 4D CEUS? And do you think we should move towards this trend?
I can answer that if you want, Dr. Wilson.
Sure, I love you too.
Do we have experience with 3D CUS or 4D? Not at this point in time at our facility. Do you think we should move towards this trend? I think there is future potential for it. Right now, we do something called quantification, where we actually measure the intensity of the bubbles as they come in. 3D and 4D might help us to do look at masses volumetrically for quantification. This is just a thought that I have. I'm not sure it's proven yet, but we don't use it at our facility at this point in time.
I'll say a little bit more about that. So, as Christine said, we do quantification of blood flow. So we do it in two circumstances. We do it to quantify neoplastic blood flow, particularly when we're doing cancer tumors of the ovary to determine their likelihood of being malignant or benign. And so we do a full time intensity curve generation with calculation of all of the available parameters. And we also do a quantification of blood flow in our patients with inflammatory bowel disease, because it's a very accurate method of looking at neoangiogenesis, in this case, from inflammatory change. And so those are both very important. Now, in terms of doing the same kinds of measurements with 3D or 4D, I believe that this does have a definite application, but it's a definite application which I believe is probably not important to many of the people who are watching this or to us. And so that's in the monitoring of tumor response to chemotherapy or immunotherapy. So let's say you have a tumor and it has obviously got dimensions in when we look at it flat on our screen, but the real dimension of the tumor may be quite different if we were looking at it in 3D or 4D. So if we're going to look at changes in blood flow as a reflection of a positive response to a treatment, it is more accurate to have a quantification that involves not just the two-dimensional measurements, but also the 3 or 4-dimensional measurements. And so in what we do, we feel that we do just sensationally well using 2D, like what we currently have. And I do believe, however, that in the future, the oncology community, by and large, will be the ones who will go forward and want 3 and 4D dimensional change.
Fantastic. We do have just about 5 minutes left of the Q&A, and then we will go into demonstrations. So next question, can harmonic imaging be used with CEUS?
I can answer that one, Dr. Wilson.
Good.
I'm going to say yes, and it's almost always part of the presets and it's automatically added to the presets with your CEUS software. What I have noticed, and I have done some contrast with and without, and I have to say the preference is to use harmonics with CEUS if the machine will allow you to use it with or without.
Yeah.
Excellent. How do you know which nodules to contrast, especially if there is no concerning history?
Do you want to try that one, Christine?
Oh, yeah. So what we do when we come out is we look at the patient history. We want to see if there's a nodule that they're specifically looking for answers. Like, so we look at the question, and we will contrast that nodule. But if we're doing a random sweep of the liver, we look for nodules that are increased in size or look unusual, and we usually make a plan to go in to start with one nodule. And we take the biggest and most ominous nodule. And then what we'll do is we'll do sweeps in the late phase and the portal venous phase to look for the detection of washout. Should we see that, as Dr. Wilson said earlier, it's a hallmark of malignancy. So we might inject on top of those nodules where we see washout. There's many other scenarios, but ideally we try to make a plan before we go in.
Yeah, actually, I'll just add a little bit to that. I appreciate so much the great questions we've got so far.
Mm-hmm.
And I'm hoping that there's some sonographers and physicians listening. But Christine's quite right. So now in our department, my sonographers are very highly trained and really capable of doing all these scans. And so they go in and they acquaint themselves with the patient's prior imaging and history. So that includes looking at prior CTs and MR scans. And so then once they've looked at everything, they'll come to me and we'll review the grayscale imaging. And by and large, the sonographers they'll tell me their plan, what they think would be the best way. And so as Christine said, of course, if there's a specific nodule that we're being asked about, then we do include that one in our plan. And if there's one nodule that's bigger and more onerous looking, we'll include that in our plan. But we also make our plan related to how things look in the liver and what's the most efficient way of looking at the most things that are abnormal. And so we do not shy away from looking at patients that have multiple lesions. I think originally the idea was that we could only look at one mass. And then for a while, it was kind of like you could look at 2 or 3. And we draw no line on how many we can look at. And many times you can do many nodules in one injection if you have a good plan and know where things are. So that's a really great question. And I think it's really important that we don't just randomly go in. You have to really have a good idea of what would give you the best and the most answers.
Matt, I'm just looking at one question here that I think would be great for Dr. Wilson to answer. I'm
Perfect.
just
And
looking
that's
at
our
chat.
last, we'll do
It'll
that
be
as
our
our last question.
last one.
Yeah.
Dr. Wilson, this question is for you from Karen saying it's a really good one. We are starting a CUS program at our facility. How do you recommend to get the most amount of referrals from other providers in our community? That's definitely the right person for this question, Dr. Wilson.
Yeah. Well, I remember when we didn't have any patients. And then, but no, it's very important whenever you have a good case, an exciting case. I always call the clinicians and I invite them to come and see the case with me. I go to rounds whenever it's possible and present the CUS on all of the cases that are being presented at tumor board rounds or whatever rounds there are available. I also, once you have a little bit of material accumulated, I go and I try to have myself invited to give grand rounds for any of the specialties. So like in our department, we would go to the inflammatory bowel rounds. We'd always, every week we go to the liver rounds. And so as much as possible, I try to give us as much runway and exposure as we can. So we don't just want to do a good job. We want to make sure we do a good job and that we tell as many people as possible what a good job we do. That's really
Tremendous. Yeah. There's so many ways to get the positive impact out into the community, and just a great success story, Dr. Wilson, as well as Christine, in building your lab and being so influential in abdominal imaging and kidney. Well, I think we're going to have to close this Q&A. We will look to save a lot of the other questions and pass those on to the staff. And now we will go into, again, this is non-CME, but we'll go into demonstrations by our sponsors.
Hello, everyone. I'm Dr. Stephanie Wilson of Calgary, Canada, and you're in our department at the Foothills Medical Center, where we perform contrast-enhanced ultrasound. And I'd like to welcome you to observe us as we perform a contrast-enhanced ultrasound exam. So now I'd like at this point for us to go on to our demonstration. So we have a volunteer patient who we will look at both the kidney and the liver. And so before we come to doing the actual exam, we'd like to go over the setup for our machine and talk about the staff that are required and the things that we require to have prior to actually doing the scan, which we will show you very shortly. Thank you. Now we're going to talk about our setup prior to doing a contrast-enhanced ultrasound scan. So the intravenous access is covered in a different session, and so now we will look at the hand, the left-hand hand, which is a typical choice as the sonographer sits on the right side of the patient. So as we look at the hand with the intravenous started, we can see that there's a 3-way stopcock attached, and you'll see that through the straight port, which you could indicate with, through the straight port is where we place the contrast agent, in that we don't want the contrast agent to go around a corner. And from the 90-degree port, we have the syringe with the saline flush. And so that's how we would like that to be. And the IV can be started prior to our original scan, or it can be started immediately prior to the contrast injection. But regardless, that is how this should look prior to starting the scan. So let's go now to actually performing the grayscale evaluation the sonographer doing the scan. And so we want to emphasize that when the sonographer is scanning the patient, that they will be on the left side of the patient, usually on the right side of the patient's right, the left side of the stretcher when you look at it from the end of the bed. And so when we do the grayscale examination, we want the sonographer to be sitting comfortably and with their arm well rested and not up in the air, so that they can hold their arm during the procedure.
So prior to doing your contrast injection, it's really important to understand the knobology on the machine that you're using. And here today we are looking at the Canon Apleo I. Looking just at the console and focusing on the console for now, you'll notice that you have your contrast software is activated by the contrast button. It's important to know where your annotation button is, your dual screen display, and of course how to start your movie clip and how to store a clip, and then the importance of the freeze button as well. It's also important to understand where your TGCs lie. They must all be even, and where your focus. And in this case, on the Canon Apleo I, the focus is this small trackball in the center. So moving to our touch panel, before you start your contrast exam, you'll notice on the Canon Apleo i800, in the top right-hand corner, you have your contrast-capable probes. Just below this, you have your automatic presets. Here you can see we have one for abdomen and contrast. If you press this button or these presets, it will automatically select your probe. It's important to know for contrast where your software is to go into your dual screen display or your contrast software. It's also important to know where your timer lies to start your timer. And one of the most important features for any contrast exam is to know where your mechanical index limit is set. And here it is, here on the Canon Apleo I at 0.09. And of course, we can move and adjust this MI limit, which is essential to contrast exams. The frequency type is in the bottom of the panel here. And here we have it set on penetration mode. And then you want to be aware of your specific frequency types before starting any exam. So prior to starting your contrast, it's really important to be aware of the knobology and the buttons that you will need in order to produce an optimal display. So on Canon Apleo I in the right-hand corner, at the top, we have our probes, our contrast-capable probes. Here we have our presets. You can see we've chosen the abdomen preset. Before we start, it's important to know how to access your contrast software. So here on the console, we go into the contrast setting, and you can see that on the monitor, we create a dual screen display. So on this display, you have the contrast side on the left, and then you have the low MI grayscale side on the right. It's important to understand where your mechanical index is. So here on the Canon, you can see that the mechanical index is at 1.05. which is a little high. So we have to know on our touchscreen how to adjust this mechanical index. And ideally, you want the mechanical index contrast to be about 0.08 or 0.09. We also have the capability on the console to move between the contrast image and the grayscale image. So we can highlight the grayscale side, we can adjust the gains on the grayscale side, and then we can highlight the contrast side, and we can adjust the overall gains on the contrast side. How do you adjust these gains? You want to adjust them a little bit high so you see some noise, and then you want to try to pull them back. So you suppress the image on the contrast side before you start your exam. On our console, you want to make sure your TGCs are aligned and straight, and you want to be aware of your focus position. So you want your focus to the back of the image or at the image. And you can see here on the monitor, Canon has two areas of focus, and we have the focus right to the back of the image. You also want to know before you start your contrast exam where your timer is. So on the touchscreen display, we have the timer start, and then we have the movie clip, And then we have the freeze button so we know where to stop.
So now we've come to the exciting part of our demonstration, and that is the performance of contrast enhanced ultrasound. So the performance of these scans requires two people, one person to do the scan and another person to do the injection. And it's quite impossible to do it with one person. And so prior to doing the scan, we want to spend as much time getting ready for the scan as we actually spend doing the scan itself. And so if we were looking at a liver, so Christine will show us beautiful sweeps in the long axis and the axial view of the liver. And so because this is a normal liver without any pathology, we will focus on the porta hepatis when we're doing our injection so that we can see the vascular supply to the liver. And so here she's just right on the porta in a sagittal orientation. And then she can just look quickly from here to the kidney to show us the patient's right kidney. And what we would do here, we're looking at a nice kidney with an echogenic focus in the upper pole of the kidney. And then we would look at this also in the axial plane. And we always show a sweep of the organ from top to bottom when we're going through in either plane. And so when she's ready to do her injection, so would you like to start, Christine, with the liver or with the kidney? Okay, so we're starting with the liver. So because, as I said, this is a normal organ, we're going to try to optimize our visualization of the blood flow coming into the organ. And Christine will, in all cases, have done prior to the injection, determined whether the patient scans best in the supine, left lateral decubitus position or other positions, whether quiet breathing is ideal, or whether the patient requires a suspended inspiration to get a good scan. So you'll see in this circumstance that she's sitting quietly on the porta hepatis and the patient breathes very nicely, and we don't need to do any suspended inspiration, and we'll do our injection. And so when Christine is ready, she motions to our nurse who is going to inject the contrast. And then our nurse will say, when she's starting the contrast injection, she'll say starting injection. And then when she's starting the saline flush, she'll say starting flush. And then when she's finished the flush, she says end flush. And this is very important because time 0 corresponds with the start of the contrast flush. So Christine has gotten ready now to go into the injection. So she's set the contrast specific scanning mode. You saw her do the adjustment of the TGC so that the image had first of all too much enhancement, and then she takes it back so that it just disappeared, and there she's turning it up, and then she'll take it back until it's just disappeared. Perfect. And that's where we like to be when we start the scan. And you can see on the low MI grayscale image that the resolution is less ideal than it was when we had just abdominal ultrasound selected. And so this is a low MI correlative scan so that we can see where we are precisely. So Christine, go ahead and tell her to start the injection.
Okay, good. 0.2 and 10 bolus.
So she said to Gert, 0.2 with a 10 bolus.
Complete flush starting.
And Gert has just said flush starting. So time 0 has started, and we're waiting for the contrast to come in. So we look with the transducer maintained at our desired endpoint for visualization. You can see immediately the contrast coming into the hepatic artery first. Can you record this? And then into the portal vein. And you can see then the parenchymal enhancement following last. And so you can see the beautiful enhancement of the liver, and that there's ideal resolution of the near through to the far field, and that the contrast distribution from near to far is really quite excellent. And so we would do the same type of injection if we were looking for a patient's mass. So we recorded that as a cine file, and you can see that we're looking again now at the arrival of the contrast. So the artery first, right there, and then the portal vein immediately beside. And then the parenchyma fills. And so you can see this all happens within seconds on contrast injection and that beautiful enhancement. And appreciate that the screen was originally black, so the contrast differential between the enhanced liver and the black background is quite profound, and it shows the extreme sensitivity of ultrasound to its tracer. So this allows us to have excellent enhancement of the entire liver. And then now we're going back to real-time scanning. So our timer tells us that we're at 1.59 seconds, so we're right at 2 minutes. So you can see that this is just towards the end of the portal venous phase, and you can appreciate the homogeneous enhancement of the liver parenchyma. And this is a slightly generous liver, perhaps with a little bit of steatosis, and so there is some loss of attenuation or increased attenuation in the far field, but nonetheless you can appreciate that we can still show beautiful enhancement of the vessels. Yes, and so you'll see that now even at 3.5 minutes we still have excellent visualization of the parenchyma. And so this late portal venous phase, late phase scanning is an invaluable technique on CUS in that if many malignant lesions show washout. So when we're doing these sweeps through the liver, you can see the normal anatomy showing the liver parenchyma and the now non-enhanced vessels as the arterial or vascular phase is over. But you can see that if there were any lesions in this liver with washout, that we would see them. So this is a very nice, successful scan. So this would be a scan that we might perform on a patient who has previously had a tumor or who is at risk for liver cancer. And when we do these sweeps that show normal, homogeneously enhanced parenchyma, this is a reassuring assessment. And so in a single injection, you can see the extent to which we're able to see the liver, and you can appreciate that we're not limited to looking in just one area on the injection scan. So you can see the beautiful definition of the vessels at the porta hepatis. And of course, if we were looking at a tumor, we would be able to look at the vasculature of a tumor. And then you can see the branching of the hepatic arterial vessels within the liver parenchyma. And so this kind of resolution is something that is ideal on ultrasound. And CUS is really the champion for showing both filling direction of tumors and also vascular morphology. And this is a beautiful depiction of vascular morphology in the normal liver on the screen that we're looking at right now. So when we look at the gallbladder, this is very much like we see when we're doing a grayscale examination, but you can see again how we can see a large stone within the gallbladder and how beautifully we can see the margin of the gallbladder and see that there's no other stones in the gallbladder and that there's no pathology related to the gallbladder wall. And so this kind of long survey that we have with a single injection, so this was just a single tiny injection of contrast agent, and how even now we're now at 7 minutes and we're still looking at this liver with beautiful retention of the contrast and excellent late phase imaging. And we can see the kidney there as well, still with contrast within the kidney parenchyma and showing the medullary pyramids that are now showing as washed out areas, or appear to be, but they're hypo enhanced relative to the renal parenchyma. And so all in all, a very beautiful injection that shows all of that. And you can appreciate that if there were any pathology in that liver, that we would see it very, very easily.
So another post-processing feature is parametric MFI. So what this does is it shows you the time of the bubble arrivals. So you can see here in the bottom left-hand corner, the first bubbles that arrive are red to yellow, and then you can see the parenchyma filling and the pink at about 8 seconds.
So in between scan injections, we used to scan out of contrast mode, with belief being that we would destroy the microbubbles in the field of view. And this is what we are doing at the moment if we're looking at our our screen, you can see that we're scanning the right kidney and we're scanning the right lobe of the liver. And we're going to, of course, do a contrast injection here. However, I think it's very important to emphasize that we no longer feel it is a necessity to remove the bubbles before we do a contrast injection. So we very often do a contrast injection on top of a previous injection when the bubbles are still in the arterial or more often in the later phase. So here we're looking at the kidney in cross section. So we're at one pole of the kidney. The patient's holding their breath, and we're sweeping all the way through the renal pelvis down to the lower pole of the kidney. And so we can see the edge of the liver as well. And we can see how nicely, again, that we can see this entire kidney. And we're starting to differentiate the cortical medullary differentiation. You can see there. And the renal pelvis is in the margin of the kidney centrally, and we don't see much, and we see no evidence of any pathology. So this is a successful evaluation of the kidney on CUS. And so now, if we want to look at this with our bubble tracking techniques and our parametric imaging, what can we see looking at this? That as the bubbles arrive, that the kidney enhances uniformly and very quickly. And so now if we do bubble tracking on this, and so then here's the replay of the arrival time of the bubbles and showing the enhancement of the renal parenchyma. And so that's beautiful, not nearly as beautiful as if we had a big mass in there to look at. But since this is a demonstration for normal kidneys, this is what it looks like. So now we're going to do the parametric MFI, looking at the bubbles arriving in the kidney. So this is all post-scan processing, and we can see the time differential of the arrival of the bubbles with the red signifying the bubbles that arrive first. But the perfusion of the kidney is invariably very rapid and uniform, as we see in this lovely normal kidney. So here when we're looking at the kidney, we've seen the bubbles arrive, and then you'll see a bright flash on the screen as we apply a right there, a transient high MI pulse, and that clears bubbles from the field of view so that we can see reperfusion of the kidney in dynamic real time. As always, but the flash technique allows us to repeat the procedure so that we have more opportunities to visualize the information that we wish to gain.
Meet the Acuson Sequoia ultrasound system. Designed to meet today's most challenging cases, this ultra-premium platform integrates cutting-edge technology with best-in-class abdominal imaging. The Acuson Sequoia gives you the power to know more by maximizing the sensitivity and depth of your scans. This video features a contrast research study with imaging on increased BMI patients, with ultrasound becoming the frontline imaging modality of choice. Caring for high BMI patients is becoming a routine task. Caring for high BMI patients was one of the priorities in the development of the Acuson Sequoia. The system's unique deep abdominal transducer, or DAX, was engineered to allow users to scan to a depth of up to 55 centimeters, thereby offering a new diagnostic tool to assist with diagnosis and treatment of technically difficult patients. The DAX transducer allows users to perform advanced applications, including contrast-enhanced ultrasound, or CEUS, enabling contrast visualization at greater depths than ever before. In addition, the DAX transducer requires approximately 70% less force compared to a conventional abdominal transducer on large model patients. The transducer uses unique multi-D beam formation technology that controls the beam thickness and beam formation, providing a new standard in deep abdominal imaging. let's explore some contrast controls of the Acuson Sequoia ultrasound system. Pressing the CEUS button will start the contrast study. Two unique features of the Acuson Sequoia for contrast imaging are, firstly, that the system allows users to set the maximum mechanical index in the field of view, which prevents bubble destruction independent of focal depth. And secondly, the system allows users to select a preset for different types of contrast agents to best optimize their contrast images. The Acuson Sequoia system's unique in-focus technology is active, ON, during contrast imaging. However, the focal zone icon representing in-focus can be depth adjusted during contrast imaging. The adjustability gives the user the most flexibility during contrast imaging for maintaining such parameters as bubble life while still providing the coherent processing benefits of in-focus technology. The tissue equalization, or TEQ control, assists the user in balancing the gain from near to far field, allowing them to spend less time manipulating tissue gain controls. The 2D and contrast gain controls are separated on Acuson Sequoia, which allows contrast gain to be independently controlled from the 2D gain. These controls are found on the control panel. If the user is more focused on frame rates, they can use a lower line density. In cases where they want to use a high line density, they can focus on spatial resolution with a lower frame rate. The system features a convenient timer control that can be set at the time of injection, which may help determine lesion etiology. Let's look at a study conducted at the University of Calgary, Canada. It was published in 2023 in the Journal of Ultrasound in Medicine by Wiley Periodicals LLC on behalf of the American Institute of Ultrasound in Medicine. In the study, the DAX transducer was used to look for solutions to imaging problems in patients with a high BMI and fatty liver. A standard curved transducer and a specially designed probe, or SDP as referred to in the study, were used to demonstrate imaging on the same patient. The SDP probe was the Siemens Healthineers DAX transducer, specifically developed to meet penetration needs for technically challenging cases. This image demonstrates a dual screen of contrast-enhanced imaging on the left and the B-mode image on the right, which was acquired using a standard curved probe. The second image, featured here, demonstrates again a dual screen of contrast-enhanced imaging on the left and standard B-mode imaging on the right in the same patient. This image was acquired using the Siemens Healthineers DAX transducer, here referred to as SDP probe. Note the increased penetration in both the contrast and the B-mode images, compared to the standard curved probe. The DAX probe clearly defines the mass. The study showed two major benefits. Using the DAX transducer, a statistically significant improvement of penetration for all degrees of fatty liver, from mild to moderate and severe, was observed. In addition, an improved detection of lesion washout in the portal venous late phase was noted. This allows the correct prediction of malignancy in a significant proportion of patients using the DAX transducer as compared with a standard probe, with the potential of removing the necessity for biopsy. Let's take a look at a kidney contrast exam. In this case study, note the kidney mass and the contrast that enhances the visualization of the subtle characteristics that were not readily visible on B-mode. Placing the focal zone at the base of the kidney, the focal zone is best used by staying just below or at the level of the area of interest. In ultrasound, especially in contrast-enhanced ultrasound imaging of technically difficult patients, or patients with metabolic syndrome, the DAX transducer overcame the limitations of standard transducers for CEUS penetration, especially in fatty liver tissue. The DAX was optimal for the liver mass characterization by detecting washout. The DAX transducer improves clinical diagnostic confidence in all ultrasound imaging modes and in advanced applications, such as CEUS, not only for high BMI obese patients, but also for difficult to scan patients with severe disease, deep lesions, and deep vasculature. With DAX technology, the need for repeat examinations or follow-up to other imaging modalities may be reduced.
Dear ladies and gentlemen, it's a great pleasure today to show you how we do a contrast and ultrasound examination of the kidney. First of all, we use some gel on our probe. We already have the patient name in the system and we start the examination of the left kidney. Therefore, it's important to change the penetration depth. Look for the wide of the scanning, and what we're also doing, we optimize the grayscale and we store some clips. After doing the grayscale examination, we go to the color Doppler and we are looking whether this lesion in the middle has got any vascularization, yes or not. Afterwards, we could use some special power Doppler, but still in this setting we could not see any vascularization. In the CT examination they describe a hemorrhage cyst, but we could not see any vascularization. In order to rule out kidney cancer, we have to do the examination with contrast sensed ultrasound. So we just check the contrast agent. In this case, we use 1.5 cc of contrast, followed by 10 cc or 5 cc of saline. Then we connect the contrast with the IV access, and we use also the saline. We check whether the IV access is fine. You see, very easy to inject. So now everything is prepared for the contrast examination. The grayscale, we go now to the contrast mode. We have got a side-by-side mode. On the one side the contrast image, on the other side the grayscale. Important to bring the focus on the button of the image. There it is. Now we are ready to start. So what I'm doing now, I inject the contrast agent, it's in, and I inject now the saline afterwards, in. Don't forget to push this timer, and it takes around about 10 to 15 seconds until contrast arrived. Now you see the first bubbles show up. There, and you see the kidney lesion, the cystic lesion, has no enhancement. So we have stored the image, then we store single frames. We also could make the measurement about the diameter of the cystic lesion. And for our reports, important to have the correct diameter. Now we are after around about 50 seconds after injection. Everything's fine, so we store some single clips to see nothing happens in this lesion. It's still black. Black means there is no contrast uptake inside. This means it's just a subcapsular cyst. It's no tumor. Now we have reached 1 minute. We just have to follow up another half minute and then our job is done in this case. In order to get the best results, it's important to make some breaks. So don't scan the whole time. Make some breaks. That means we scan 10 to 15 seconds, make a break 30 seconds, then scan again. Okay, nothing changed. And make a break. So we just store a single image, and now the job is done. We know it's a subcapsular cyst of the left kidney. There is no tumor. This means no treatment, and there is no need for follow-up. I would like to thank you for attention, and if there's any question, just send me mail. Thanks for attention. Again, bye-bye. Hello, my name is Professor Klebert. Today I would like to give you a lecture how we do contrast enhanced ultrasound of the liver in our daily setting. First of all, we make a decision which probe we should use, the linear probe or the curve array probe. In this case, I would prefer the curve array probe. So we just need some gel on the probe. Patient name is already inside the system. And we start our examination. So we're looking for the liver. So we optimize the penetration depth. We're looking for pathologies. And we see very easy in the right liver lobe, there is a lesion. And now we have to optimize the setting. So we optimize the penetration depth. We place a focus at the area of interest. We use the grayscale brightness. Then we store also some clips. Additional, we would like to look for the vascularization. So is there any vascularization or not? Nicht atmen. So. Vascularization, you see a lot of vessels, but no major vascularization. Then we look for the same by color Doppler. Also we see in this case a lot weiter artifacts. Okay, we have seen there's a lot of vascularization in the peripheral, but no vascularization in this liver. The patient suffers from fever and she doesn't feel well. So in the next step, we have prepared everything that we could go on with a contrast setting. For the contrast setting, we just change the program. We go to the contrast mode. We put the focus on the button. That's very important, because otherwise we destroy too much bubbles. Then we optimize the grayscale in this setting, and we also look for the contrast image. Okay. So everything is now prepared that we can go on with injecting contrast. So important to check the bubbles. It should be like a milky stuff. Then we use round about 1.5 cc of contrast in this case. And additional, we have to inject some saline. Get rid of the air, so it's fine. Connected now the contrast agent and the saline. We have to check whether the IV access is fine, so it's very easy to inject. Now we inject saline in a straight way. Therefore, we just look for the setting. Okay. So we inject contrast. Contrast is inside. Then we inject saline. We have got a window up to 10 seconds. And you see very easy a strong uptake of this lesion. Very strong uptake. Don't forget to store the image, make a break, because otherwise you destroy too much bubbles. You can also magnify the image a little bit. Okay, you see this lesion has got a very strong rim enhancement. So probably we know already the diagnosis. This patient suffered from an abscess of the liver. That's the reason why she doesn't feel well and she has got fever. So we're looking again, how does this lesion behave? You see very nice this lesion here, strong rim enhancement, no washout. We already have reached 1 minute after injection. Now we make a break and wait a little bit. Round about 20 to 30 seconds we wait until we go back to our real-time setting. So this is round about 1.2 minutes. So we go back, live setting. You see also there is a lesion. Typical for this lesion is that you have got a very strong rim enhancement. Don't forget to measure this lesion also in the contrast setting. So we see the complete diameter of this lesion is around about 8 centimeters. Now we are very close to the late phase. Late phase starts normally after 2 minutes. We have reached 1.5 minutes, so very close to 2 minutes. And after 2 minutes, we do the same. So we are looking for this lesion. You still see no washout. Typical for this lesion is an abscess. Additionally, what we can do, we can also change the probe and look how does this lesion looks if we look for the linear probe there. So we go to the settings, we optimize it, we go directly to the contrast, and we see very nice also in the linear probe in the side by side, there is a lesion in the center. There is a lesion with the rim enhancement, no uptake inside. And you also see that this really works fantastic if you think about linear probes and imaging of the liver. And how does this lesion also looks for the grayscale? So we go out of contrast. So we go back to conventional grayscale. So we optimize the penetration depth. You see very nice this lesion. There's subcapsular lesion. We see also the structure inside. Don't forget to measure and save some images. Look for the vascularization. You see also an improved vascularization in the periphery. So I told you we can also do the same examination if we use the linear probe. In the meantime, I have adapted some new contrast agents to the IV access, round about 3 cc of contrast. I go back to the grayscale, I optimize the grayscale, then we go to the contrast image. You see on the one side the grayscale, on the other side the contrast image, side by side. And now what I have to do is I inject the contrast agent. Contrast is on the way. I also inject some saline. Don't forget to push the timer. And you see very similar like you've seen for the curve array, very strong rim enhancement of this lesion. So typical for this lesion. There's also a second one. You see there's a connection between the first abscess and the second abscess. which you have not really seen clearly in the basic information, in the basic examination. So we store the image, then we make a break. In the moment we are in the portovenous phase, this is round about 30 seconds after injection. Now we wait a little bit, round about a half minute, and then we go back to the live scanning. So we are now very close to 1 minute. Then we are going back and scan again. You see very nice rim enhancement of this lesion, the connection for the second abscess here. And you still see hyper-enhancing rim. This is typical for an inflammatory abscess. So we make a break, we measure again, we store the image. Now we are close to end of portovenous phase because it's 1.5 minutes, and after 2 minutes the late phase will start. So just a couple more seconds and then we have got the late phase. So we get back. You see still hyper enhancing area. You see no bubbles inside because we have got a pure intravascular contrast agent. Now we have reached 2 minutes. You see 2 minutes there. Again, we store some image. There is the image. We measure it. And I think this will be the end exam of the examination. In case you have got any questions, please send me a mail. I'm very thankful for your attention and I wish you a great day. And also very thankful that our patient accepted for this documentation. Thanks again and see you soon. Bye.